Yeah, so hi everybody. So this is, I have kind of compiled it in such a way that a little bit of clinical experience. Many of you might not be exposed to a lot of foot and ankle stuff. So I thought I'll just put in a little bit of clinical stuff also along with the teaching stuff. So it would be useful in your clinical practice as well as for your exams. Not kind of hopefully trying to cover up many things, but not much in trauma, because I think trauma otherwise also you would be covering up otherwise. But depending upon few exams questions, I have made this. So let's start. Uh, Guys, who would be like, what do you see in this particular slide, and what is the sign called?
PK.
Who's going to be interactive? I mean, can you, Balu, can you help in pointing out people's names?
Sure, sir.
Krakow virus.
Too many
Krakow virus.
So it's called as a peekaboo sign. Okay, what are the common conditions associated with this? I can't see the participants. Okay. Okay, I can't see the participants actually.
Yes, sir.
Yeah.
Sir, we have Gautam, Nandu.
Okay,
Karthik.
Nandu, what are the common conditions associated with KO virus?
Cerebral palsy.
Cerebral palsy, okay.
Then poliomyelitis.
Pardon?
Congenital equinovirus.
Okay.
Then poliomyelitis.
Okay. Poliomyelitis is not usually cavovirus. It is a planovalgus deformity. So here in cavovirus deformity, you have an intrinsic type of muscle. What is it called as an intrinsic muscular spasm. So that leads to the cavus deformity. It is the intrinsic small muscle spasm which leads to this problem. So when you have flaccid things like polio, then it is a planovalgus deformity. So remember, in foot and ankle, there is a cavovarus deformity and a planovalgus deformity. So when the foot is in cavus, there are three components in foot you should always remember: the hind foot, the midfoot, and the forefoot. So hind foot is in varus, the midfoot is in cavus, and forefoot is also in varus. That is the cavovarus. That is the structure that is cavovarus. And in adult, with the most common thing is the Charcot-Marie-Tooth syndrome. This is how a foot would look like when you look from all the aspects. Look at the hind foot. Behind, this is more than your exam OSCE. I thought I'll just start with something clinical. You guys should know what it is. Cavus foot has got yes, congenital conditions like CTV, this thing, as you said, CP. But in adults, most commonly, this is called as the Charcot-Marie-Tooth syndrome. Okay, so what this is one of the very commonly the question which is asked. What is it?
Coleman blasters. Find the rigidity of the hind foot virus. Whether the hind foot virus is flexible or rigid.
Yes. So one, there are two questions. I mean, what two inferences with this Coleman's block test? One, whether the hind foot is flexible or not. Hind foot is flexible at which particular joint are you looking at?
Subtalar.
Subtalar joint. So if the subtalar joint is mobile, is it flexible or not? And second component,
Is it due to the metatarsus formation?
4-foot driven virus.
it is a 4-foot driven varus. So here, if you look at it, I have allowed this block test. It is the toe is allowed to dip down. Okay. So the moment it is 4-foot driven varus, the varus disappears. If I elevate that first metatarsal, then the varus reappears. So that means it is a 4-foot driven varus and it is a flexible varus. So these are the two inferences which we get from a Coleman block test. Okay, so this is how it is. The moment normally you see here, the varus is there, the peekaboo sign is there. When the block has been put, the first metatarsal is allowed to dip, then the varus disappears. So the hind foot varus disappears, and there is you have allowed it to the first metatarsal to dip inside. So that is called as a 4-foot driven varus. Understand?
Yes, sir.
Yeah. So this is the things which you should know about a cavo-varus thing. How do we treat is a long story. I don't think it's a exam related question, but at least we should know what it is to be done. Okay, so depending upon what is it rigid or is it subtle, it is moving, you treat it in different ways. Now, more exam related, what is the sign called?
Too many toes.
It's too many toes.
Too many toes sign. Okay. What are the conditions when it is seen? Now this is one of the commonest questions. I think you have got it in your DNB questions.
Post dysfunction.
Akhil.
Tibialis.
Akhil,
It's a tibialis posterior tibialis posterior tendon dysfunction.
Okay.
Peroneal muscle spasm. And traumatic congenital.
Peroneal muscle spasm. Okay. Very less likely. Peroneal spasm will not lead to. It will not lead to too many toe signs. It will lead to heel valgus, but it will not lead to too many toe signs. This is only
tarsal coalition.
Tarsal coalition. Good. So these are the two things. The tarsal coalition leads to a rigid flat foot, planovalgus deformity, but the most commonest is a tibialis posterior dysfunction. What is the other name of tibialis posterior dysfunction?
Adult
Acquired flat.
Planus.
Adult acquired flat feet. Okay, so the patient or the person particularly had a normal foot to start with, but following the posterior tibial dysfunction, this leads to this particular deformity. So it indicates the tibialis posterior dysfunction. So what is the anatomy of tibialis posterior? Anybody?
Tibialis posterior originates from the posterior fibula, posterior part of tibia and interosseous membrane.
Yes.
It has three slips of insertion. The anterior slip inserts at the navicular tuberosity. The middle slip inserts at the and the second to fourth metatarsal base, and posterior slip inserts at the succent.
Yeah. So it is mainly the anterior middle slip which is very important. The one which is attached to the navicular is one which is important. So what are the deformities that are caused because of this tibialis posterior dysfunction? You see this particular X-ray, this picture. Now the important part which I want you to be as a clinician is when you see a patient with a pain in the foot, look from behind. because when you look from front, you miss out a lot of things. You don't see the heel at all, especially a female, an obese female with a sari. You won't see anything from behind, from what is happening in the behind. So that is why clinically, as a clinician, you should always look the patient from behind, standing. So what are the deformities of this particular, what does it lead to?
One is
Heel
Anybody
valgus.
else other than, say, who's
Heel
the
valgus. Heel valgus, midfoot planus.
heel valgus,
Midfoot planus.
And forefoot.
midfoot?
Midfoot planus. Planus.
Midfoot planus, okay. Or it is called as a midfoot collapse
Forefoot.
actually. The arch
Okay,
is
forefoot
completely collapsed.
abductor. Forefoot
and-
abduction.
And forefoot
Forefoot abduction.
Forefoot pares.
forefoot abduction. It is a forefoot abduction, but many a times you find the toe, big toe into varus. That is a hallus varus deformity. That is, you find it in a late area because to balance the patient's the big toe kind of goes for varus. But it is the forefoot abduction, midfoot collapse, and hindfoot valgus. Okay, so these are the three components of the deformity. And what is this particular heel raise test identify? And what is this, what you're seeing?
so to
Patient
heel
able to stand in big toe.
Beg your pardon?
Whether the patient is able to stand in toes. Big toe.
Why? What are you looking at?
to see whether
Whether
the deformity is correctable. sir.
Posterior
Whether-
is functioning or not.
No? Anybody
Just to
else?
check for the rigidity of the pes planus. Sir.
Rigidity of the
Pes planus. If the patient stands on the toes and then the medial longitudinal arch appears, that means it's rigid. It's flexible.
no, but that is the same thing.
Is-
Whether it is
is there
rigid or
only a
not, we are
tendinitis?
talking about subtalar joint, right?
Yes,
Since
sir.
stage 1, or if there is only tendinitis or
So
so in
For
tendinitis,
staging purpose, sir.
stage 1,
stage 1.
there is
So that
only a
leads to-
inflammation of the
That leads
tendon.
to what is the classification?
So stage 1, 2, 3, and 4, sir.
Do you
One is-
have any name of the classification? Do you know that?
Johnson.
Johnson and Storm.
Johnson and
Johnson.
Storm classification, yes.
Stage 1 is stenosynovitis.
Mm-hmm.
Stage 2 is flat foot with forefoot normal and forefoot normal in stage 2A, forefoot abduction in stage 2B. Stage 3 is flat foot with forefoot abduction and hindfoot valgus, and stage 4 is forefoot abduction, hindfoot valgus, flat foot, and ligament compromise.
Ankle.
Ankle is involved here. Okay, so this one is a heel raise test. Is actually what is the function of tibialis posterior? When you raise your heel is brought to varus. So you look at this particular side, the heel is going into varus. Can you realize that?
Yes.
Yes, sir.
Yeah. Here, if you see, I mean, this is the fullness of tibialis posterior. Patient has got a dysfunction of tib post, and the heel is not going into varus. He can do a heel raise test, but the heel is not going to varus. Now, if you ask the patient for a single heel raise test on the affected limb, the patient itself cannot raise the heel. Okay. So tibialis posterior function is to raise the heel and bring the heel into varus. So this is a simple test, not exactly to differentiate between stages, but whether the tibialis posterior is functioning or not, and whether the subtalar joint has become rigid or not, right? So this is single heel raise test is not possible if you have even synovitis because of the pain. So it is not basically for the staging, It is just to diagnose clinically that it is tip post dysfunction. All right. So now we said about this is the other name. We have talked about the anatomy, so this is how you examine. Too many toes sign, varus heel swing on tiptoes, single foot tiptoe stance is not possible. And no, when you walk, there is a valgus thrust while they walk. Okay, and you should look at the under part for the foot canal. So what is the thing is, you send these patients for MRI, CT scans, and all will be reported normal. And you say there is no problem for the patient. Or they might say that there will be some amount of tenosynovitis of tip post. They will not see what are the problems. So that is why the diagnosis is clinical, and that is what I'm trying to tell you. So this is the clinical part, not exam related many times, but you should know when to identify and how to identify. And this is what I was saying, how the midfoot sag increases and the forefoot valgus increases. And this is how the foot is seen from behind and from underneath. So investigations are all useless. It is clinical diagnosis, and this is the x-rays which you can look at it. I'm not going to go in detail. The calcaneal pitch, the Meary's angle. These are the two things you should learn, the Meary's angle and the calcaneal pitch for most of the foot problems. So this is the classification. This was the older classification, Johnson and Storm, and this is the Truro classification, which is the newer classification. So one is tendinopathy, 2 is flexible deformity, 2B is forefoot varus, flexible deformity, but the forefoot varus is more than 15 degree, and 2C is a little bit fixed, 3 is fixed deformity, and 4 is including the ankle joint. Okay, so there are a lot of, I don't think you are asked at your level about the treatment part, but there, depending upon the stages, there are different type of treatment, and ultimately you do an arthrodesis if it becomes a rigid thing, right? Something which I again want you to know is, because I have learned it in wrong way, lot of people send this footwear modification, and you say, okay, you have an adult flat feet, you go and buy a medial arch support footwear. Isn't it? Have you learned that way? Please unlearn this. Here the patient does not need an arch support. It is the hind foot that has gone into valgus, and that is the problem. So you need a medial wedge to correct the hind foot deformity, and the moment you correct the hind foot deformity, the arch will reform. So don't give the arch alone. It is the wedge, the medial wedge, which is very important when you send the patient for a footwear. If you, most of the people will send for a footwear, and this orthotist will give you an MCR footwear with a big medial arch. The patient does not wear it because it is very painful, because the heel is still in valgus and you're thrusting the midfoot. So these are the clinical part, not exam related, but you should know as a clinician. All right. Now going to the next part. What is the diagnosis here? Spot diagnosis.
Achilles tendinopathy.
All right. What is the difference between the upper one and the lower one? It is already there, but what is the difference?
The lower one is Achilles tendinopathy, sir. And the upper one is tendinitis or retrocalcaneal bursitis.
This is Karthik, correct? This is Karthik, right?
Yes, sir.
Okay, Karthik, what is the difference between tendinosis, tendinitis, and tendinopathy?
Tendinopathy is degenerative change due to poor blood supply at the watershed zone. Whereas tendinitis is due to repetitive microtrauma, there is inflammation happening, and that is tendinitis. Tendinosis.
Anybody else?
Tendinosis is the degeneration of the tendon. Tendinitis is the inflammation. And
Yes.
tendinopathy is a combination, say, in between the tendinosis and tendinitis.
Yes.
I mean,
So
sorry,
tendinitis is a plain inflammation. Itis, inflammation. Tendinitis is a plain inflammation of the tendon. There is no structural damage there. It is just the inflammation. So early tendinitis, early stages called as a tendinitis. There is no structural damage. Okay. Tendinosis is there is a structural damage there. It is passed through the inflammation. It has got a micro trauma. It can have some amount of structural changes. And tendinopathy is a complex of, it is more or less a part of tendinosis, but little more calcification, micro trauma. It's all complex is called as a tendinopathy. Am I clear? Yeah. So you understood the difference between tendinosis, tendinitis, and tendinopathy, right?
Yes, sir.
So here in Achilles, you have two different areas of tendinosis. One is the insertional tendinosis, and one is a non-insertional. Just at the, as you said, I think the Karthik said, the watershed area, the tendon structure, wherein you have this micro trauma leading to tendinosis, right? So there are two different areas of the problem here. So can anyone describe this finding of a X-ray? Can you read up this X-ray? Who will read up this X-ray? Amal, somebody who's Amal, sorry. Who's that?
Haglund.
Where is the Hagland? There are two arrows: the top arrow or the side arrow. Which is the Hagland?
Top arrow. Top arrow.
Come on.
Top arrow, Haglund.
Top arrow.
Top arrow is the Hagland. And what else?
The bottom is calcification, sir.
Calcification. So can you describe it in a complete way?
It is a calcific tendinitis secondary to Hagland's deformity of calcium. Sir?
I missed. Can anybody say about this? I mean, how will you read out this X-ray in an exam?
So it is an X-ray of the lateral view of calcaneum. A calcification at the site of insertion of the tender Achilles. It is well-defined smooth round calcification along with projected bone of the posterior superior tubercle of calcaneum, which is the Hagland's deformity.
Yes. So very good. What are the components of this disease complex here now?
So one is the calcific tendinitis, and other is the Hagland's deformity.
Wonderful. So what is your modality of treatment here?
So we'll have to debride the calcific region, sir, and we'll have to excise the Hagland's deformity.
So you're talking typically about a surgeon. Any other treatment?
So we start with non-operative treatment first.
Yes.
Activity modification, non-steroidal anti-inflammatory drugs, shoe wear modification,
What is a shoe
And,
wearer? What will you do?
So a shoe which typically comes in contact with the posterior surface, we should avoid which.
Okay. You give a little bit of a heel raise to decompress
Yeah.
the Achilles pull, right? So heel raise footwear, heeled footwear, and the one which backstrap which does not irritate the Hagland, and the retrocalcaneal bursa. So the most common problem here is the retrocalcaneal bursa, which is creating the pain. Okay. So, and the eccentric and the eccentric exercises. That is very important. The physiotherapy also includes the eccentric exercises. So you try to stretch your gastroc Achilles complex, and the pain many a times goes away. You have the x-rays, it need not be operated in the first line. So never say your surgery is your first line treatment, and never practice also in first line treatment. Always try to do physiotherapy, get your patient moving your gastroc, and then if it does not subside, then you think about surgery, right? And if you do surgery, make sure all your calcification is gone here, your Haglands is removed. Now you have to remove your calcification all the way from here, right? So that is something which you do about surgery. But more than the surgery, you should say, I will manage it conservatively with physiotherapy, exercise, eccentric exercises, and shoe raise. And then if the patient does not feel better, then I can think about surgery, right?
Yes, sir.
Okay, so what is Thompson test?
So with the patient in prone position and ankle in 90-degree, in neutral position, we press the calf region, which is the area with most of the bulk of the calf, and then there will be plantar flexion of the foot.
Okay.
If the continuity is maintained, there will be plantar flexion. If there is a breach in continuity of the tendinosis, then the plantar flexion won't be present.
Okay. Dr. Christo, are you there?
Yes, sir. Yes, sir.
Christo, can you see the difference between the two legs, the position of the foot?
Yes, sir. The
On
foot on
inspection,
which
what do you find?
the foot on which the hand is placed appears okay, and on opposite foot is some edema over the lower leg and calf region, and the foot is in neutral position, not foot is.
So which is a problematic, the one with hand or without the hand?
The one
Without.
with the hand.
Without hand. Very good. So this is how the practically Thompson test is done. You can see my hand, I'm squeezing, and the foot goes into plantar flexion, and here there is no continuity of the Achilles, and that is why this is not functioning. So this is the Thompson test, fine? Right.
Yes, sir. Thank
so what is the treatment? Enumerate the causes of Achilles tendon tear. What are the causes of Achilles tendon tear?
Forceful
Papers.
plantar flex posture. Sudden forceful dorsiflexion for plantar flex.
Forceful dorsiflexion or plantar flexion, fine.
And any direct trauma, laceration.
Direct trauma.
Okay. Something we are what we do find nowadays lesser and lesser. Very common in northern India. What is it?
Indian toilet injury.
Indian toilet. Yeah. So that is still there. So the sports injuries is one of the commonest cause. Sudden dorsiflexion, sudden plantar flexion, fall from height. And there are in Indian toilet, this is something which you should remember. This is the picture which you should remember. I hope you can see the foot. It's faint, but this is how the Indian toilet injury is And depending upon the area of injury, I mean the high level injury or the low level injury, the foot is dorsiflexion or plantar flex. That's how the injury happens. And one of the very common injury in when the people are using the Indian type of toilet, we used to see a lot of things, a lot of times when we were PGs. Now, at least in Kerala, it is way less, is the one which is dangerous because it is a direct injury. You will have a little bit of a, the dirt, the ceramic particles inside your foot. So you should be very, very careful when you're looking at a low level injury in an Achilles tendon injury, with an Achilles tendon injury, with a history of closet injury. Okay? So this is something you should keep in mind. High level injury, the low level injury. And low level injuries are more dangerous. And one more cause is the quinolones, fluoroquinolones, especially the Cipro and the ofloxacin. They are actually known for problematic because of the deleterious effects of the tenocytes, right? So these are the causes, the sports injuries, fall from height, the toilet injuries, and drugs like ciprofloxacin or the fluoroquinolones. How will you manage? Sanjeev. Who was there? Anybody?
We can initially, if the patient not active or said,
You've been answering too much. Let other people answer. Anybody?
So for acute injuries, we can go for a functional brace. And chronic injury, it has to be end-to-end tendon repair.
Okay, so acute injury. What are the two types of treatment recommended?
Conservative and surgical.
Conservative and operative. Conservative is
above AK, under AK flap.
Okay. So actually, what you said is the age-old tradition of AK cast in plantar flexion, and then keep it in plaster plus for 6 weeks, and then put that is gone. Conservative treatment is very, if you can do conservative, you have to do an ultrasound guided conservative treatment. You see you plantar flex it, look at the ultrasound and see how much of approximation of these two ends are coming. And then you immobilize only for about 2 weeks and then start weight bearing. There is no non-weight bearing here. After 2 weeks, you start weight bearing and then you decrease the plantar flexion to normal flexion in about 6 weeks time slowly. And every time you have to do, so there is this Canadian study which has got, that is the present recommended by the world over. That's how you do a conservative management. It's not any longer cast management like before. Okay? So conservative has got very good results like surgery, but it is a very proactive treatment and lot of cast plaster change every 2 weeks. It is not like, put the plaster and send him home. All right. What is the problem between conservative and what is the problem with conservative treatment?
Recurrence of
high chance of re-rupture.
So slightly increased chance of re-rupture, and second, more importantly, is the elongation. Healed in an elongated way, so you don't develop back the tone of the muscle. Okay, so these are the two problems in conservative management. What is this problem in the surgical management?
Infection, wound healing.
Pardon?
Wound healing, sir.
Good. Wound healing is the most commonest part of the surgical problem. Okay, right. Now, I've been asking questions, and I can see Karthik and Nandu answering regularly. Rest, everybody is on a silent mode. So I think everybody can kind of switch off or come here. There's no point of trying to keep everybody on mute. So I think, shall we stop here if everybody is on mute?
No, sir.
If I think I should see people unmuting themselves and becoming more active if you are here. Yes, I don't know who are there here. You know, I see everybody is on the muted way. Okay, so good. I can see at least some people have unmuted. Now, what are the treatment for chronic injury? Some share.
The defect we can question the edges and suture it directly.
Pardon?
If the defect is small, we can freshen the edges and we can suture it directly.
Okay. So
And if there is a gap, direct repair. And if there is a gap, we can augment it with plantaris tendon or fascia.
So you take a plantaris tendon and repair it. Okay. So what is how much of gap can you use for plantaris tendon?
2 centimeter.
If it is more than 3 centimeter.
Have you seen a plantaris tendon?
Yeah, very small.
Very small. Do you think
It is fanned out.
It has a strength to hold the torn Achilles for 3 centimeter gap?
Less than 2 centimeters.
Less than.
Plantaris tendon is actually used to cover the repair. It does not have the strength to hold the gap.
Leeway lengthening of the tendon.
We use the flexor hallucis longus tendon.
FHL tendon, okay. So when do you use FHL? Do you have a dictum? I mean, when you're writing or when you're talking, how will you manage a chronic? You have to be having a protocol.
Classification.
What classification are you talking about? Treatment protocol. I'm not talking about any classification. I'm talking about treatment protocol. This is the commonest question asked in a chronic Achilles. What do you do? How do you a chronic?
So we have to degrade the unhealthy tissues. Then we have to assess how much thickness is left. If it is less than 50%, we have to think of augmenting the repair with the FSL transfer. Or if it is more than 50%, we can think of direct repair and using bone anchor.
It's not more than.
We cannot hear.
I think sir lost the connection.
I lost it again.
കുഴപ്പമില്ല, ഞാൻ പറഞ്ഞോളാം. അതെന്തോ ക്ലാസ്സിന് എന്തോ ഒരു അറിയില്ല, ഒന്ന് പറയുമോ?
Okay, I'm back. Can you hear?
Yes, sir.
Yeah. I'm sorry. I don't know what's happening in between. So I will show you by pictures how do you do this. So so this is the end-to-end Krakow sutures. This is just for a visual aid. Okay, end-to-end sutures. Actually, today we did it one and I forgot to take the pictures. So Krakow sutures, end-to-end anastomosis, and that is how you do it. If it is more than 3 to 5 centimeter, then you have different ways. Okay. So one is VY-plasty. What is VY-plasty? Open up a whole thing, make a V cut here, pull it down, and it becomes a Y now. All right. So now you have aponeurosis is sutured here, and now it becomes Y, and this is the one which bridges the gap. All right. There is another thing called as a turn down flap. You take the aponeurosis and turn it down underwards, and that's how you cover the flap. So the problem with all this VY-plasty and turn down is the amount of, you see the amount of big incisions. So the problem of wound dehiscence was very common. So now most of us have switched over to FHL, the flexor hallucis longus tendon, because though it is small, but FHL is in the same same phase of triceps surae, and it's a vascular bundle. It's a vascular muscle. So you get to repair that. So that is what FHL reconstruction is. All right. So this is the protocol you should remember. If it is approximated possible, then try to repair it end to end. If it is less than 5, then you can try without FHL by doing VY-plasty or a turn down flap. Otherwise, if it is more than 5, try to get an FHL tendon and augment with the existing tendons, existing remnant of the Achilles tendon. All right. So this is the present day dictum. You can use the other things like Pantaris, facial atta, allografts, and all that, but the present this thing is about FHL. Okay. So this is just a visualization so that you will remember when you write it in an exam. Okay. So now coming to the different thing, what is this test called?
Anterior draw test.
Anterior draw test. What is the significance of anterior draw test? Dr. Christo.
Sir.
What is the inference with anterior draw test?
Integrity of ATF.
Tibiofibular ligament.
Tibiofibular ligament. Anybody else? Shinaz.
For anterior tibiofibular ligament insufficiency.
Anterior tibiofibular ligament insufficiency. Anybody else?
Anterior talofibular ligament.
Anterior talofibular ligament. And anything else? Pardon? So the lateral ligament, I didn't put further slides on it. So this is the lateral ligament complex injury. It is formed by 2 major ligaments. ATFL is not tibio, it is talo. Anterior talofibular ligament and calcaneofibular ligament. Okay, you can go back. I forgot to put the slides of how does it look anatomically, but anterior tibiofibular ligament and anterior talofibular ligament and calcaneofibular ligament. All right. So
Yes.
what is the treatment? Varsha. What is the treatment? To have a ligament sprain, ankle sprain, how will you treat? Somebody is there or not, or just on theoretically? Okay, Sanjeev. Varsha is just absence. Okay, Sanjeev.
Sir, ankle sprain can be treated with proper rest, applying ice packs, limb elevation, use of ankle binder helps in immobilization.
Okay.
And a proper below knee slap.
Okay.
MRI.
If you find this in knee, anterior dramatous positive, you will say ACL tear and you will say about surgery. Why not?
MRI.
Okay, you are right, but why not surgery here?
Sir, initially maybe try with the conservative management, and if it doesn't respond, may progress to surgery.
So it is not maybe. Even if it is grossly unstable, the ankle ligament 81% time. That is what this thing is. 81% ankle ligaments heals on its own by scarring. Okay.
Yes, sir.
81% of the time, even if it is grade 3 or grade 4 instability, you can actually move it completely. But you just if you can really move it, put him on a plaster. Otherwise, what you said is the RICE therapy. Okay, rest, ice, compression, and elevation. So the RICE therapy is what is recommended for all the ankle sprain, irrespective of the grade. If it is very severe, then you put him on a plaster, put him or her on a plaster.
Yes.
And when do you think about surgery?
Even after plaster, pain doesn't subside. Or
When? In 2 weeks' time? 1 week time? 5 days' time?
3 to 4 weeks, sir.
That's it?
Sir.
Anybody else?
2 weeks.
So you wait for at least 10 weeks. 8 to 10 weeks. Okay, 2 months minimum, if not more. And if still patient complains of instability, so there are two aspects of ankle problem here. It's about the instability and pain. Okay, if it is just the pain and unstable, it is stable, then you don't think about surgery. To manage with physiotherapy, rehabilitation of the peroneals and the lateral ligaments. Only if it is unstable and painful, then you think about surgery after 2 months. MRI, again, here is not important. You don't take MRI and say, okay, you have an ATFL and CFL, so I'm going to operate. Okay, there is no point, because most of the MRIs, many times you'll find a thickened or a scarred ATFL and ankle would be stable, right? So that is just more about clinical part rather than theory. Okay. A C sign in talocalcaneal. Oh, this is already there. I've told the answer. Sorry. So this is one of the question, which is that what is the diagnosis here? The answer is already there. And somebody can say, point it out where exactly is what I'm saying. This is one of, I think this was one of the question a year back, DMB question that had come. What is the sign called? And the answer is there, but how? What is it about the whole thing? What do you understand with C sign, and what is it importance?
The medial dome of the talus and the posterior aspect of the supranucleum talus. Produces a C sign on the lateral X-ray.
Yeah, so if you look at the C sign, this is what is the C sign. Okay, so that is what is the C sign. Why it is C sign is because of this particular problem. There is a coalition between the talus and the calcaneum in the medial side. It is not in the lateral side. It is in the medial side, and CT would show it like this, and that is why it is showing the C-shaped C sign in the talocalcaneal coalition. So what are the different types of coalitions you know of?
Partial coalition.
Partial coalition, general term.
Calcaneonavicular, calcaneonavicular, and talocalcaneal.
Calcaneonavicular.
All right. Which is the commonest one? Calcaneonavicular is the commonest one. Okay. This is one place where you find a rigid flat foot. Okay. So calcaneonavicular coalition can lead to a rigid flat foot. And you might be giving some medial arch support and patient has severe pain. You got to look at coalition as a severe cause of pain in the mid and the hind foot, especially in the growing children. All right. So what is the treatment here? How will you manage? In this particular thing, how will you manage?
Excision of the
Excision of the
that are affecting the.
Yes. So in a younger individual, it is managed if it is fibrous or bony. In a younger individual, it is managed by excision of the bar. In a middle age or older individual, the arthritic changes has already set in the subtalar joint. You do a subtalar arthrodesis along with it. Otherwise, the pain doesn't go away. Okay. So in, the management is in younger individual, excision, and in middle age to older individual, it is arthrodesis of the subtalar joint. So I am talking about the talocalcaneal coalition. Okay. Right? Now coming to the foot. What is the sign called? Or can anybody read this X-ray? Jisam. Jisam, are you there? Hello.
Hawkins sign.
Read the X-ray. Read the X-ray.
The X-ray of ankle body showing
I can't hear you, Jisam. You look very far away. Okay. So you said about Hawkins sign. Who is Surek? Can you say what is Hawkins sign?
Hawkins sign is the revascularization of the talus after 4 weeks, and the revascularization start from the medial side.
Good. What is Hawkins sign actually in this particular X-ray? Can you say that what is Hawkins sign?
subchondral osteopenia.
Subchondral.
There is a subchondral osteopenia here. You can see that. Okay, I'll show you another other thing. So this is in the subchondral lucency, relative osteopenias. So is this Hawkins sign good or bad?
Good.
Good, sir.
Good. So that means it shows some kind of revascularization. So the possibility of AVN is always there, but it might occur very late. And it progresses from medial side towards lateral side. Why? Because the deltoid vascularity comes from the deltoid ligament. Right? So that is why it comes from medial side to lateral side.
Yes, sir.
Okay?
Yes.
So this is what we always look at any X-ray at 6 to 8 weeks time. Okay, it's not like it doesn't come immediately. The second X-ray, you take your X-ray 4 weeks or 6 weeks, and then you start seeing this X-ray signs. Okay, it at times it might be just partial. It might not be complete, but partial also is a good indicative of revascularization. At least it means some kind of revascularization has occurred. Okay, so Hawkins sign is a good sign, and it is usually seen after 6 to 8 weeks. Okay, coming to trauma about again. So what does this indicate?
Plantar ecchymosis indicating Lisfranc injury.
Mid-tarsal.
Lisfranc injury. What is Lisfranc injury?
Sir, Lisfranc ligament is a ligament connecting between the base of the second metatarsal and the medial cuneiform.
What are different
An
types
injury
of
to that.
Lisfranc injury?
There's Meyerson's classification, where it is total incongruity, partial incongruity, and displacement.
You start with first one is
Total incongruity.
No. There is a soft tissue Lisfranc injury and a bony Lisfranc injury. What you said about the classification with Meyerson's addition is the bony injury. So there is a soft tissue component alone where there is X-rays are normal, but what is it? The flex sign or the space between the first and second metatarsal is increased. So that is the soft tissue. So you start with this. There are two types. I mean, the soft tissue Lisfranc injury and a bony Lisfranc injury. And in bony, you said about this particular classification. Okay. So always start with the soft tissue also. Here the X-rays will be normal. So this is very important, especially in a body trauma. When you see this ecchymosis in the plantar aspect, you should suspect the Lisfranc injury. Now coming to the foot part, what is this called? What is this? This is a spot. I mean, this is OSCE spot. Pardon? Bunion. No. Diagnosis. Spot diagnosis.
Alex.
Alex?
Hallux rigidus.
This is hallux rigidus. Why? Because a patient, I'm trying to dorsiflex the toe and it is not moving. That is the hallux rigidus. Okay. This is because of the osteoarthritis of the first MTP. It is not bunion. It is the hallux rigidus. And the treatment is exhaustosis. You just remove the bone formation, or if it is completely gone, you do an arthrodesis. Okay. So that is how the hallux rigidus. These are all spot. This thing you should know about it. What is this? Now this is one of your main questions of foot. Hallux valgus. Tell me more about it. Come on. Classification, treatment, what all are there? Different types of treatment. This is the main question, I suppose, right? There is a short case also. Yeah. Anybody?
For classification, mild classified into mild, moderate, and severe. As per the hallux valgus angle, less than 25 is mild, 25 to 40 is moderate, and more than 40 is severe.
Yes.
So if it is mild, we go for initially we have to take conservative with wide box.
I can't hear you. Can you be louder?
Sir, in these patients, we look out for any MTP arthritis is there, and is there a hypermobility way?
Okay.
And whether is the first MTP, is it congruent? And based upon the severity of deformities, all these will have a bear on the treatment part.
Okay.
Because if it is a first MTP arthritis, then we can just go for a MTP fusion.
So you're talking from stage 4 onwards. Okay. What is stage 1?
Mild cases we can give conservative treatment with toe box, wide toe box, and toe space. It will not treat the deformity, but it will prevent the if the patient has signs of pain and further progress of deformity, then we can go for treatment with osteotomy.
So we can, depending upon the deformity grade, we can, in the surgical, we can go for soft tissue and bony procedure.
So I think I forgot that. So anyway, so the treatment for hallux valgus is depending upon the severity. Okay, so the mild, you don't operate. You manage it conservatively with heels, between a spacer between the two toes, or you have a hallux valgus brace and all. Okay. The painful one is the one which we operate. Hallux valgus should never be operated if it is cosmetic for cosmesis, unless it is very severe. It is the bunion which is painful, it should be operated. And initially, there is no arthritis changes here. And so we try to do osteotomies. You have the proximal metatarsal osteotomy, you have the distal metatarsal osteotomy, and you have something called as an Achilles osteotomy, which is a closing wedge osteotomy of the proximal phalanx. So you have the chevron osteotomy, you have the scarf osteotomy. There are so many types of osteotomy. There are more than 300 osteotomies described. So I'm not going into it, but basic thing is proximal osteotomy, distal metatarsal osteotomy, and Achilles osteotomy. These are the three things you should remember. And in the last stage, when it is grossly arthritis, you talk about the MTP fusion. You don't talk about MTP fusion in a hallux valgus normally. Is that clear? So hallux valgus, you should never do about arthrodesis, or you should not talk about arthrodesis. You should always try to salvage the joint, because mostly it happens on a young female, and you want to try to give as normal foot Am I clear? So
Yes,
this is a long question. You should know about it. I thought I had included the slides. So just to go about the other things, the hammer toe, it's a PIP joint problem. It's a flexion deformity of the PIP joint. The mallet toe, it is the flexion deformity of the DIP joint. Okay. And claw toe, what is claw toe? Having all the deformities together. Okay, the PIP and the DIP joint all together forms the claw toe. You understood the difference? The claw toe, mallet toe, and the hammer toe. And this is the hallux rigidus. So these are the 3-4 things you should know about the toe deformity. More about theory, it is more about the spot diagnosis. You should know about it. Again, lastly, just before we close, spot diagnosis. What is this? 59-year-old with non-healing ulcer.
Charcoal
foot. What is okay? Is charcoal part of your questionnaire? I'm not sure. That's why I'm asking. Do you want to know about it, or just that's it? Charcoal foot. Do you have questionnaire for charcoal? It comes.
Yes, sir. It's kept in the OSCEs also, and even as a short case, it has been kept in a couple of DNB exams.
Okay. So this is Charcot foot. This is the X-ray. Can anybody read about this X-ray, or what are the stages of Charcot? Or can you define what is Charcot foot?
It's a neuropathic foot with we depend upon the staging. The structure, the foot structure changes from the fragmentation, collision, and reorganization.
There is a definition, Gautam.
Yes.
A relatively painless, progressive, degenerative arthropathy of single or multiple joint due to underlying neurological deficit. Okay, so this is the definition. You cannot change the definition. This is the definition, and this is what you should know. Named after this guy, Jean-Martin Charcot, and it has got so many causes. The commonest cause here now in our times is diabetes mellitus. It used to be Hansen's disease before, and the Tabes dorsalis, etc. But now we commonly see in diabetic the two theory, the neurotraumatic and the neurovascular theory. Okay, and these are the things. Sensory, you have the monofilament test. The skin is thick and deformities are seen, and this is how the changes are. A different type of X-ray changes. So you should actually know the names: hypertrophic, bone destruction, subchondral sclerosis. All this you should know when you're asked to read up or when you're asked to write up about the Charcot foot, right? The inedium bone scan is very important, not the normal bone scan. The inedium WBC scan is important. And this is the classification. Okay, Gautam, you're talking about the classification. Tell me about it.
So the Eigenholes classification is the most common classification currently we use, and it is into 4 grades. So stage of edema, then fragmentation, coalition, and reorganization.
Good. So this is what Gautam is talking about. Stage 0, here the X-rays are normal. The patient has got swelling. Bone scan may be positive, and this is the time we all miss the bus. This is the time when the patient is being treated as cellulitis and given antibiotics, and patient is sent home. This is the time you can actually save the foot. So here, this is the time you actually have to give the patient absolute non-weight bearing and put him on a total contact cast. because this is invariably going to proceed to stage of fragmentation, wherein all the bones are going to burst off, going to disappear, and then it subsides and leads to coalescence, and then reconstruction, wherein the whole bone forms back in whichever position it is. So if you look at this particular X-ray, when we saw the first X-ray, this is the stage of coalescence. Everything is come back to normal, but the whole of talus is destroyed. Everything is gone. The hindfoot is in gross varus. So this is what you should prevent stage by stage. Treatment are different upon the different stages, but always try to treat early, and that is where the importance of total contact cast is. So you should know about this. You should know to identify about this as a clinician, and for your exam going, you should know about this total contact cast. So look for the temperature, monitor the temperature difference, and keep on going this. You might have to go for at least 6 months. It looks to be very long, but this is how you can save the foot, you can save the limb by amputating, and patient walks normally. And then there are these other things which I'm not going about it. Okay, so thank you very much for your patient listening. I hope I've covered a lot of things, but not all the things, especially trauma, calcaneum fracture, blood supply, all that is still there. I thought it's already long, so I think I'll stop here. Any questions? Everything above head. Balu, are you there?
Yes, sir. Yes, sir. Wonderful session, sir. I think we had very good interaction also. We learned a lot. Any questions?
Any
anyone?
questions, guys?
So there is a question. How
Yeah.
to clinically identify stage 1 of Charcot?
Stage 1 of Charcot?
Yes, sir. Yes,
Yeah, so that is what I said in this particular slide. That is this Eigenholes classification. If you look at it, Eigenholes is the stage where it is a typical look of a cellulitis. Okay, the limb would look cellulitis. Your X-rays would be normal. The blood investigations would be normal. So when you see a red, warm, not hot, red, warm limb, but the cell counts are normal, the sugars are high, HbA1c is high, then your first suspicion is not cellulitis, it should be Charcot. Okay? So that is where you have to diagnose in Charcot, and that is where you have to sit patiently and talk to the patient, saying that this is a possible catastrophe that can happen. Let us put you in a plaster. Let us see whether you are getting better or not. And I don't have the slides now, but I have the slides where I send this patient home, and 2 weeks time when we took the check X-ray, we found the whole fragmentation happening. But the patient was on a plaster, and we saw the whole fragmentation, coalescence, reconstruction in the plaster, but we can't stop the destruction of the bone. That is the problem. Once it starts, it goes on to all the cascades. So only thing is you can stop the destruction in such a way that you can hold the foot in the shape. So the X-ray might look terribly wrong in 2 months' time, but the foot shape is maintained and patient is neuropathic, he will walk on it. You have saved the foot from amputation. So it is more of a clinical diagnosis. Diagnosis with the investigation is incidium bone scan, which we unfortunately don't have it. All right. Anybody else?
Yes, sir. That is a very important point to not mistaking it for an infection. So we have even seen patients coming with an IND for a stage 1 Charcot.
Yes.
So it can really mimic an infection.
Yes, definitely yes. So this is, I mean, I always tell my DNBs, and I'm telling all of you, foot and ankle is one place where clinical examination is very important, including your ankle sprain. You don't send the patient to MRI because MRI will come with something and you're not treating the MRI. Ankle sprain, you have an ATFL, CFL tear, but you're still putting on a plaster. So you don't need to do an MRI. You have to, and it's all hand and foot. You have small joints. You got to identify where exactly is their source of pain, and that is where. So look, feel, and move. That is what is the dictum in foot and ankle. Do that, and for exam-related questions, you should know the 3-4 things. One is tibialis posterior dysfunction. This is something which all the seniors, including me, I have missed it when I came out. I became foot and ankle after 10 years of my MS ortho. So I have missed plenty before. So tibialis posterior dysfunction, you should know about it, theory as well as practical. Charcot, you should know the theory as well as practical. Hallus valgus is one very important part. It is plenty of theory, but you should know the salient features of hallus valgus, and of course the trauma part. These are the 3-4 things which you should know, and the fourth one is the Achilles tendon. These are 4-5 things which is very important in the foot and ankle.
Yes, sir. Wonderful, sir. You summed it really well. I think Jisar is also here.
Yeah, thanks, Dr. Rajesh Simon, for your valuable time. It was a very, very nice session, very interactive as well. Thank you, Rajesh.
Thank you, sir. Thank you, sir.
Thank you.
Thank you.
Good night.
Thank you, sir.
Thank you, sir.